Hi, I'm Dr. Jared Gardner, and I'm here today with my awesome dermatology residents and Dermpath fellows, and we're going to do some random unknown cases. They have not had any time to preview these, and actually I have not either. I just pulled them out of a box of my teaching slide set, a random box, and we'll just go through them and see what we find. And if it's no good, I'll just delete the whole thing and you'll never see this. So, in any case, so here we go, guys. So no pressure. It's all good. I don't expect you to have to know these right off the bat, but here's one: punch biopsy, some deep inflammation, an ulcer, and then something here. Any takers on this? What's that? See, it's kind of thick. See how when I focus up like this, you can see it in focus and the rest of the tissue's out of focus? So that three-dimensionality, that's one thing that, as much as I love digital slides, that's one thing digital slides don't do really well, at least not without extra help, it seems. And I do use that a decent bit. It's just kind of adds some subtle nuances to the thing. It shows me that this is a thick piece of something in here, thicker than the tissue itself.
It looks foreign. I don't know
Yes.
if it's like tick mouth parts.
Oh, very good. It is foreign, and it is tick. Very good. Yeah, this yellow, dense, refractile stuff here, this is chitin, right? A type of, I guess, carbohydrate that forms the exoskeleton of arthropods. And, you know, ticks are arthropods, arachnids, right? And the mouth part often gets stuck in. So what a tick bite usually will show is the features of an arthropod bite reaction, which, of course, is superficial and deep perivascular dermatitis with, usually, a bunch of eos, particularly, just like any arthropod bite, eos down deep, right? You'll often find eos deep, and not just around the vessels, but scattered out here in the interstitial space between the vessels. Sometimes it's hard to tell if eos are present when there's a lot of blood. See, there's a lot of hemorrhage here, and there are also a lot of eos, but I find it harder to look for eos. Now here they're numerous, so it's not too bad, but when there's a lot of hemorrhage, you got to kind of hunt a little more for eos. But I'll tell you, the way is when you go to higher power and you see the eos there, especially if you flip your condenser, maybe it won't pick up on here, but erythrocytes, red blood cells, are smooth, and eosinophils have like little granules in their cytoplasm. Yeah, I can't get it to show up on here, unfortunately, but you can see on a light microscope that there are little tiny granules in the eosinophil cytoplasm, and here, look what's happening. The granules are degranulating. They're spilling all the eosinophil granules, and eventually they'll start to coat the collagen fibers, and when they get really thick and the collagen starts degenerating, it makes a little cute structure called a flame figure, and that's the classic buzzword for Wells syndrome, which is eosinophilic cellulitis, a kind of idiopathic process that resembles dermal hypersensitivity reaction or arthropod bite reaction. But I feel like because I actually see, you know, arthropod bites way more often than what true Wells syndrome, I see flame figures and numerous eosinophils, most often probably in bug bites. Look at that. They're like eos all lined up around a adipocyte. Isn't that cool? I don't think it means anything. It's just pretty. I'll have to get a picture of that later. That's really cool. All right, so lots of eos, superficial and deep perivascular. Sometimes in bug bites, or arthropod bites, you can get vasculitis or even thrombi, and look, that's what we're seeing here. See, there's like thrombosed vessel right here. Fibrin thrombi filling the vessel. And then some neutrophil and karyorectic debris, nuclear debris here. So there's actually kind of a secondary vasculitis incited by the arthropod bite. You can see that also under scabies. You can see fibrin thrombi under scabies. But all right, back to the arthropod mouth part. So usually when there's a chunk stuck in the skin still, it's usually going to end up being a tick mouth part. And ticks have this unique thing that around the dermis, right around where the mouth part is, gets really homogeneous, smudgy pink stuff that looks like kind of a mixture between either fibrin or sclerotic collagen. And my understanding is this is kind of like a cement sort of material created by the saliva of the tick that helps like kind of seal the mouth part in there. I've read that somewhere. In any case, though, it is kind of a unique feature. So when I see a bug bite that's got an ulcer, that has this real dense, smudgy pink stuff, I tend to cut deeper to see if I can maybe find a tick mouth part. I mean, you could still say, well, it's suggestive of an arthropod bite, and it could be a tick, but I don't see a mouth part. But that's nice. And I've heard that stingers, like from a bee or a wasp that are embedded, I've never seen one in my practice yet that I know of, but they could look a little similar to this. I think they have some barbs on them, but they can look kind of similar because they're chitin. And of course, other things like scabies or botfly or tunga, penetrans sand flea, all of those will have kind of similar chitinous kind of exoskeleton, but they'll have different shapes and different locations, right? Scabies is much smaller and is sitting in the stratum corneum. Tunga is like 100 times bigger than this and kind of in this same location, but massively, massively bigger, way bigger than a regular punch biopsy. Botfly is also much bigger than this. So you can kind of use those clues to put together what's going on. And let's see what happens if we polarize this. You know, not everything that's foreign polarizes. So what I found is that you will sometimes get a variable amount. Oh, hold on. Let me put, I got to turn the auto exposure off. It's really hard to, sorry. It's hard to successfully polarize on a camera sometimes because it always wants to correct the light. Let's see if I can do it. Get it in focus. Well, that's about the best I can get. You can see kind of a yellowish to even green. Looks almost like apple green, like an amyloid. Isn't that interesting? And then the bright white stuff here are probably little specks of maybe like bandage material or something like that, or some, you know, fibers from a, you know, tissue, something like that that has gotten stuck there. So that bright white is usually the polarizing we see, like in, you know, synthetic foreign material, or, you know, little bits of, you know, sand or grit from the soil. But chitin has kind of a unique appearance, a unique look. And sometimes things like scabies will have chitin, and then it will have little spines that polarize bright white. Look, it'll have little areas that are brighter polarizing. So just so you know, now we've seen what that looks like. All right. And then that'll come back into focus there. Well, that's just fun. If you don't like that, I don't know how to make you happy. Tick mouth part with arthropod bite reaction, and just a good reminder that you can have thrombi and sometimes vasculitis in association with arthropod bites, and also with scabies infestation you can have thrombi. We published a paper about that a few years ago. And look at all those EOs. Look at that. Amazing. All right. Probably enough from that tick. Let's see what's next. This is fun too. What's going on here? Anyone?
Is this like Masson's tumor?
Very good. Yeah, some people call this Masson's tumor, which I use I use it when discussing, you know, with you guys. This is Masson's, but in my reports I actually say organizing thrombus. Sometimes I'll say with papillary endothelial hyperplasia, because that's what Masson's quote tumor actually is. It's not really a neoplasm. It's just a funny pattern of organizing thrombus where the thrombus starts to get wrapped up by endothelial cells and recanalated in a way that creates lots of little papillary structures. So this is quite beautiful. Look at that layering, huh? You're kind of seeing layers of blood and fibrin that have kind of settled out over time and produced this nice thrombus. And you can tell this is not a fresh new thrombus because it already has little tiny capillaries starting to form right in the middle of it. So as you know, when fibrin, you know, when blood coagulates and makes fibrin thrombus, you have basically three options of what can happen. Either the fibrin undergoes fibrinolysis and breaks down and dissolves, right? Or the thrombus becomes totally eventually organized, which is basically kind of the same idea as granulation tissue. It kind of becomes like granulation tissue and eventually scars down and totally occludes the vessel, and then new collaterals have to develop or something, or be used. Or you get kind of a recanalization, which is a combination of organizing and making new channels through that thrombus, and then you kind of create like a new kind of vascular system. So that's kind of what's happening here. See, there's little vascular channels coming through here. And sometimes as those channels develop, they can become kind of complex, interconnected, and anastomosing. Features that we often think of in angiosarcoma, right? And also the endothelial cells can get a little bigger because they're reactive new endothelial cells. And just like in granulation tissue, endothelial cells that are new and actively growing tend to look a little bit more plump and juicy and kind of scary sometimes. So the idea, and my understanding is that and I've not read Masson's original paper, like I think from the late 1800s. I guess I probably should pull that and get it translated. I think it's in French. But the idea behind it, I believe, was that this tumor can have resemblance to angiosarcoma, but it's inside of a vascular space rather than infiltrating connecting channels in soft tissue. It's in the middle of a vessel or a thrombus in a vascular space, or a malformation or a hemangioma, something like that. So almost always when you see Masson, look what we have in the background. If we ignore the thrombus for a minute, we've got these big open cavernous channels. You can see it best over here. See the big channels? And down here, big channels, right? With kind of a thin muscular layer and then a lot of fibrosis around it. So you could call this a cavernous hemangioma or a venous malformation. That probably a lot of the things we call hemangioma in pathology, particularly in Dermpath, probably are actually a form of malformation, and people like to debate over those things. But when they're benign, it usually does not matter. And so what happens anyway, though, is that as the thrombus gets recanalized and organized, let me find a good area. Oh, there, see? Look how much it's starting to look like granulation tissue. You're getting endothelial cells, some reactive myofibroblasts in there, intermingled with the blood and the fibrin, right? And then eventually, what happens is the fibrin starts to break apart into little tiny islands, and as those get wrapped with endothelial cells, you end up getting papillary structures. And those papillary structures originally will have kind of a fibrin in the core, but over time they seem to like turn into fibrosis. At least that's what it seems like is happening to me. Like here, this stuff is starting to look almost like, like actual fibrosis, but you get these little floating islands, and so those are really little papillary finger-like structures, but when we're cutting them in cross-section, they look like little tiny islands floating in the middle of this space. So the things that help me in this is in the middle, at high power, it can look really complex. Just like if you go to granulation tissue up close, it can look kind of scary. Same thing in an organizing thrombus / papillary endothelial hyperplasia / Masson tumor, whatever name you like. But when you go to lower power, you'll see that you're inside a pre-existing vascular space, and usually you do not have, other than with the exception of inside like the great vessels, like the aorta or the vena cava, in those great vessels you can have sometimes sarcomas, including angiosarcoma, arise in the lumen. It's pretty rare, but it does happen. But in the vessels like out in the extremities or near the skin, I don't know if I've ever seen a case of like intravascular angiosarcoma. So just once you see that you're inside a pre-existing vessel, that's very reassuring. One exception is a unique tumor, epithelioid hemangioendothelioma, which we're not going to go into today. And I've got a couple of little short videos about that. But it actually usually arises inside of a vein and then grows outward. So it's kind of an exception to this rule, but it looks quite different than this. But anyway, that's the key, is at lower power you see you're in a dilated vascular space. And then you see that there's, in addition to the little interconnected channels, you start finding the papillary structures, and they're wrapped by a single layer of bland endothelial cells. And then you'll find other areas, usually, at least some areas, depending on the age of the lesion and how far along the process is, that have the smudgy, bright pink fibrin to tell you that you actually have a thrombus. And if you're lucky, you'll find areas where you can see that transition from thrombus into the papillary structures, actually happening. I don't see a perfect example of that here. Sometimes you can see it really nicely. But this is still a good example of organizing thrombus. And so the last point I'll make before moving on is that that I find that a lot of times, we think of malformations as being a thing in childhood, but I see malformations in older adults all the time. And I think what probably happens is they may have had this malformation down in their subcutis or something for a long time until it gets thrombosed for whatever reason later in life, and then it becomes either painful, or if it's near the surface, it starts to turn like colors and turn, violaceous or purple, blue, black in color, and starts to raise concern to the patient or to the dermatologist or treating physician. Maybe there's melanoma, maybe there's something going on bad, or the patient says it's painful, and then it gets sampled. So I feel like a lot of times when I get malformations, they have some degree of thrombosis or organizing thrombus in them, because I feel like that often is related potentially to what's making them present to get the lesion, checked out and removed. So that's kind of my theory, at least from what I've seen in practice. So nice example of intravascular papillary endothelial hyperplasia, Masson's tumor. All right, so here's low power shave biopsy, clinical rule out melanoma. Anyone can get this from 2x?
I think it's kind of a junctional nevus.
Yeah, junctional nevus is one idea. Any other things in the differential?
Lentigo?
Lentigo, good. And sometimes it's really hard to tell junctional nevus apart from lentigo, because there are, pretty common type of nevus that has a lentiginous pattern. And it kind of has overlap with dysplastic nevus. Sometimes it has elongated reedy, increased pigment, but then when you look closer, you'll see little nests of melanocytes and single melanocytes. And so I like to call those lentiginous nevi or lentiginous junctional nevi, because clinically they look like a lentigo or like a dysplastic nevus, a thin, kind of spreading out macule that has sometimes a little hazy border and oftentimes has a lot of pigment. So when we go closer, we see elongated reedy, we see a lot of pigment, and it does look like nests, right? But this is, of course, when you start Dermpath, this looks like, oh, those must be nests, must be melanocytes. But once you've done this for a little while, you recognize those, what look like nests, are actually enlarged tips of the reedy, right? And those pigmented cells are actually keratinocytes, not melanocytes. And so for any beginners watching this, I know my residents all know this, but any beginners watching online, if you see a really darkly melanin-laden cell in the epidermis, it's usually going to be a keratinocyte holding melanin pigment, not a melanocyte. So it's kind of paradoxical. And if you see a really darkly pigmented brown cell in the dermis, so here's the keratinocytes, all of these. And in the dermis, if you see a really heavily pigmented cell, it's usually going to be a melanophage, a histiocyte or macrophage that has eaten up melanin that's fallen down from the epidermis. And so usually not going to be a melanocyte. Now, there are exceptions. There are both types of nevi and sometimes melanoma that have a really abundant pigment. But more often than not, melanocytes have kind of a pale gray cytoplasm. And when they have pigment, it's just kind of a little powdery brown, not this real dense, chunky brown. But here you can see perfectly, this is like kind of the hockey stick shaped. Let's see if I can say that. It kind of looks like a hockey stick. At least that's what I said for my fellow Caitlin Campbell a couple years ago. She's from Canada, so in honor of her and her husband, who's also a pathologist, I always like to say they look like hockey sticks for my Canadian viewers. And then also, or looks like a boot, or like, Italy, maybe, mirror image of Italy in this case. But in any case, though, what happens is these reedy elongate. They get increased pigment in the basal keratinocytes. And let me bring it up here so you can see the cornea there. That looks prettier. And then what happens is if you have a perfect cut, you can see the whole thing. But if you go over here, look what happens. It looks like they're islands floating. But if you were to cut deeper into the block, you would see that this connected up to the reedy. It's just like right here. Look. Imagine if you cut just a little deeper, you would no longer see that connection. And so you have to think in 3 dimensions in Dermpath, even though we're looking at a 2-dimension slice of tissue. There's really 3 dimensions to it. And so that takes a little bit of practice at first to be able to visualize that. But that's what's happening here. And, one way you can tell is, look, all those things that look like nests, they all line up right where the tips of the other reedy are. See? They're just lined up perfectly at the same kind of level as the reedy tips. And if you really struggled, you could do a stain like SOX10, and what you'd see is scattered melanocytes in here, but that all these pigmented cells are actually SOX10 negative, and they'd be cytokeratin 5-6 and P40 positive. I mean, you don't need to do these things. If I am worried about a melanocytic proliferation in the background of a lentigo, I'll do a SOX10, or you could use a MART1, that'd be fine. So this is just a solar lentigo. With practice, it's an easy diagnosis to make on H&E. Ooh, a little bonus too. Very subtle. I don't know if we can get it to pick up, but see that pink stuff right there in the papillary dermis? That pink stuff with little cracks in it is keratin-derived amyloid. It's the stuff that we see in the diseases called macular amyloid and lichen amyloid. It is not related to systemic amyloid or light chains or myeloma or anything like that. Not related. It is just pigment. It's just keratin and other proteins that have fallen out of the epidermis and kind of congealed together in the papillary dermis. And you can see it in macular and lichen amyloid, but you can also see it in association with seborrheic keratosis, or occasionally, I guess, lentigo, basal cell carcinoma, a wide variety of epithelial lesions. So nice lentigo, but why would we, put this in a study set? Oh, and you could even also, if you wanted to make the argument that this out here is either a lentigo with big cells, see how the cells get much bigger and puffier? Or you could say that it's a large cell acanthoma, which is a lesion that I think of as basically a solar lentigo, usually one without the reedy, that has bigger cells. And no, while we're talking about solar lentigo, I will say that this is the classic pattern of solar lentigo with the long reedy that look like boots, or, and Ron Rapini likes to call them dirty puppy dog feet, that they look like the little feet of a little puppy dog that's run through mud puddles or something. But the other pattern, and one that I see just as often, maybe even more, is basically a flat atrophic epidermis with underlying solar elastosis that has increased melanin pigment in the basal layer. So kind of like this. And then when you get that pattern with larger cells, some people call it large cell acanthoma. It has a lot of overlap to me with pigmented actinic keratosis. See, the cells are bigger and kind of jumbled at the basal layer. But you don't have parakeratosis. And normally in an AK, an actinic keratosis usually has para, although some people say, well, pigmented AKs don't have para. And so I think that's because some people call them pigmented AK and some people call it large cell acanthoma. And in most of my career, I just called them solar lentigo, or I'd say solar lentigo and pigmented AK because they often mingle together on the same biopsy. And I didn't say large cell acanthoma because I felt like a lot of the colleagues I worked with were not as familiar with that term being used, and I didn't want that to create anxiety. But here, everyone uses that term, so I'm fine with using it. And so if you're wondering about, well, what does melanocyte look like? Here we go, look. These are melanocytes right here. That guy with the gray cytoplasm, that one right here. And if you're watching online, I have a video about melanocytes versus keratinocytes that kind of shows some really perfect examples and some easy ways to tell them apart. And you can check that out. I'll try to put a link down below. Okay, so anyway, now long tangent of discussing everything you could ever want to know about solar lentigo. But why do we recut it? Well, this is why. What is going on here? Lentigo still, right? We can see not as pretty as the other, but longer reedy with increased basal layer melanin pigment in the keratinocytes. But what are these? And more importantly, why are these? This is kind of esoteric. Here's a closer view. Anyone want to take a stab at what those are?
Dead keratinocytes.
Dead keratinocytes, apoptotic keratinocytes, or some people say necrotic keratinocytes, or dyskeratosis, dyskeratotic cells. We use all sorts of different names. But usually when we see apoptotic, dying keratinocytes in the epidermis, we think of it as a thing that goes with interface dermatitis, right? Like lupus, or a lichenoid variant of interface, like, lichen planus, in which case they're at the junction, the basal layer. But here they're like floating along in the mid layer of the spinous layer. And they're actually all throughout. There's more of them over here. There's like little clusters of them, and they're all throughout the specimen. So I had a hunch when I saw this case a while ago, and I thought, I think I know. I remember this case really well because it was the first time I ever got to confirm this. I was like, I think that I know why those are there. I think this patient might have an acute sunburn in addition to their chronic sun damage and solar lentigo. And thankfully, there was a clinical photo of this lesion, and the skin, the entire skin of the patient's back was bright red, really bad, recent sunburn. And so yes, they had chronic sun damage with the lentigo, but in addition, they had a recent sunburn, which was clearly visible on the clinical photo, and it was so great to have a confirmation. So these are what's been called sunburn cells. So when you get an acute sunburn, if you're wondering what sunburn looks like under the microscope, there it is. Parts of the epidermis get damaged so much that they die, and of course that will eventually repair itself. The keratinocytes will, but the potential DNA damage, has already been done and may or may not repair itself. So if you're watching this online and curious, if you're not a non-medical person curious about sunburns, that's what sunburn looks like. But even though that stuff will go away and get fixed, some of the cells may have had their DNA damage, which can lead to the production of precancerous lesions like actinic keratosis, or even squamous cell carcinomas, basal cell carcinoma, melanoma, other types of cancers later. So this is why we try to avoid excess sun exposure, as my awesome derm residents all know very, very well. Okay, there we go. Sunburned lentigo. How about that? Who can talk for 10 minutes about lentigo and sunburn? This guy right here, all right? I hope that you're all laughing, maybe crying a little bit at home, but since I know you're all on mute, I can't hear it, but I'll pretend that you are. Pity laughs are also accepted. What is this? That's as low as I can go, low power. Got a big slab of tissue here. And I know I can't get it right side up because it's all multiple pieces oriented different ways. This is not normal skin, right? Goodness. Well, first of all, what's going on here? Here's this epidermis. And you can see the dark pigment here. This is a darker skin patient. That's why they have diffuse basal layer pigment. So sometimes if you have a small biopsy and you're not given the history of what skin type or ethnicity a patient is, it's hard to actually figure out sometimes, is the pigment due to a lentigo or some pigment producing process, or is this their normal pigment? So if you have a big enough piece of skin, you can figure it out. So here's a more normal-ish. It's not really normal. There are dying keratinocytes in here. And this is more abnormal than the other. So there's dilated blood vessels, and look at the epidermis. It's starting to detach. It's dying. See, there's a split here that's happening. The epidermis is losing its contact with the basement membrane, starting to lift off. Part of that is an artifact of processing, but probably this skin was ready to slough off. And if it would have been left in the patient another couple days, it would have like actually fallen off and made a big either blister or an open raw ulcer. And the epidermis is starting to get very pale. See how it's like that very pale pink color? And that's because it's undergoing necrosis. It's starting to die. And usually when we see that's a sign of ischemia, like thrombi. And in this case, it may be partially due to that, but the reason for the thrombi, I don't think is, normally we see that and we think thrombi from like, DIC, diffuse, or other thrombotic vasculopathies, systemic hypercoagulable state, angioinvasive fungus, stuff like that. But here underneath, we have other stuff. Aside from the dilated vessel, we got tons of neutrophils, like abscess, basically. So over an abscess, you can have death and destruction of the skin. You can also see that we're beginning to have kind of vasculitic change in here, probably all secondary. And you know what? I never really talked about this, but look at that. Those look like little tiny possible fungi, right? But actually those are little strands of fibrin. At least I believe. I see this sometimes. They're way too small to be fungal hyphae, and they're too variable in size, right? There's little ones, a little bit bigger ones. Fungal hyphae are usually pretty uniform tubes, and these are little tiny fibers. So when fibrin first starts to form in a vessel, it makes little tiny fibers like this, and then eventually it all smashes and congeals together. But early fibrin thrombus I have seen before, and it made me think about, oh, could this be fungal hyphae? But now you know. I think this is something that I never really see this in books or talked about. I've just noticed it in practice and thought, oh, that could be easy to get confused with fungus, but it's not. So let's go over to this piece over here. So we've got basically what looks like abscess, and then in addition to that, we're getting kind of vasculitic change, lots of vessels that are beginning to get fibrin thrombi in them, right, like right there. And then let's go down further, and now this tissue's dead. It's necrotic, almost all necrotic. Has kind of a bluish haziness to it. And I'm trying to find them, but oh, there. See if we can get it to show up. Bacteria. Numerous cocci bacteria. In this case, there may be other bacteria present. So while this, depending on the clinical, this could be an abscess, but other things that could have this extensive necrosis with inflammation and numerous bacteria, so numerous that they make colonies that are, look, I mean, they're everywhere. They're just, this tissue is dying and being overrun by bacteria. And so necrotizing fasciitis could look like this, although you really don't want to make that diagnosis unless it absolutely fits clinically, because it's a very serious diagnosis, right? And I've seen things that look like neck fasc, but were just post-op, surgical site infection that did not have, gas production and did not have extension along the fascia. And in this case, this skin was from the scrotum. And the scrotum was basically turning necrotic. So this is what's called Fournier's gangrene. And I've not done reading on it recently to understand the exact etiology of why it happens, but it's a very rapidly progressive, infectious gangrenous process in the scrotum, unfortunately, which is, of course, a terrible sight to have that happen, and can be a really serious and severe problem for patients. So that's what's happening here. Necrosis, tons of neutrophils, bacterial colonies, secondary death of the epidermis, and in the clinical context, Fournier's gangrene. So, busy, right? Lots of stuff going on in here. We look at all the pieces of tissue. So this is a vascular lesion, right? Multiple big dilated vascular spaces that have variable thickness walls. Some are thin-walled, some are a little thicker. There's a lot of fibrous stuff around them. So when we see these big dilated spaces, we call them cavernous spaces because they're large like a cavern, right? And so, again, cavernous hemangioma or venous malformation or just benign vascular malformation would be a totally great thought for what we have here. Additionally, we have blood that is beginning to form thrombi, and in this case, this thrombus actually has been here for a while because you can see it's starting to be perforated by small vessels, just like we looked at in the case of Masson's tumor, papillary endothelial hyperplasia. So this is that same process just a little earlier. This is organizing thrombus here, fibrin thrombus, and note the difference in color between the pink fibrin and the bright red of the erythrocytes. Sometimes blood packed together like so, at first glance may look like a fibrin thrombus, but when you go closer, the color is different. And also, if you flip your condenser, you can really see in each individual red cell, even when they're smashed close together, with especially if you flip the condenser, you can see, oh yeah, they're actually individual red cells there. It's not fibrin thrombus. This is fibrin thrombus with organization. So right now we're at vascular malformation or cavernous hemangioma, whatever you like, with some organizing thrombus. Ooh. There's more organizing thrombus. Oh, look. And it's just starting to make a couple papillae. See? We caught it in the act right there. We see it in the process of making papillary endothelial hyperplasia, aka Masson tumor. Look, right here you can see it also. See those vessels that are kind of dividing up this fibrin? They're beginning to carve out little chunks of fibrin. Now, if you see this pattern in the dermis, then you really have to think about angiosarcoma or Kaposi or a few other things. If you're seeing individual collagen bundles in the dermis getting wrapped by invasive infiltrating endothelial cells, that's concerning. But here in the middle of fibrin thrombus in a big cavernous vascular lesion, no problem at all. So really the context matters a lot. But what's this? Calcification. So what happens is sometimes thrombi, particularly big thrombi, they can calcify, and we get what's called a phlebolith, right? Like a thrombus stone. So, and you can even, when they're big enough, you can even see these on x-rays or little tiny specks of radio opacity in the middle of a soft tissue lesion. So that's kind of cool. So what is interesting about this? Well, now it gets a little different looking over here. So we kind of have a biphasic lesion, right? We've got a lesion that has big cavernous areas that look like cavernous hemangioma with some thrombi and calx. And then over here we have a more cellular zone. And the more cellular area is composed of more spindled endothelial cells that have little compressed, I hate to say the word, but slit-like vascular channels. If you're having a bad day, it could remind you a little bit of Kaposi sarcoma. The appearance with practice is actually relatively different, I think. But the compressed thin channels that look kind of slit-like and have blood in them, with spindle cells in between, do bear some resemblance to Kaposi sarcoma. But Kaposi sarcoma, almost every case I've ever seen that's been in the skin at least, is in the dermis. It may involve the subcutis, but I never see like a nodule of subcutaneous or intramuscular Kaposis. At least I've never seen, and I'm sure there are people who've seen a lot more Kaposi than me, but I've seen quite a few cases. I have seen it in organs or lymph nodes, that's a different story. But in the skin, it almost always is a dermal process at first that extends later on, maybe further down. But what we have is these slit-like spaces, spindled endothelial cells, also some kind of more plump, rounded, or epithelioid almost endothelial cells. And I'm looking for the one last thing I want to show you. May not have it in this case, but hopefully we will. Well, can't have everything. Oh, that'll do. See this couple little vacuoles here? They look like tiny little fat cells. So those are actually not fat cells. Those are endothelial. Let me move that pointer out of the way, see if I can get the light better. Those are endothelial vacuoles. You can have vacuoles in a variety of different vascular lesions, particularly when you have epithelioid endothelial cells, more rounded endothelial cells. They seem to be more inclined to make vacuoles. But in this lesion, the vacuoles have this kind of striking resemblance sometimes to clusters of little fat cells. And I've got another video on this entity online that has this. So when you put all of this together, this is called a spindle cell hemangioma. And these are a benign vascular neoplasm. And they have a tendency to be multifocal, like within the same, limb or extremity, like the same region. And so early on, people called these spindle cell hemangioendothelioma. My mentor Sharon Weiss was co-authored the kind of landmark paper on this entity in the early or the mid 80s. And then later, though, they went back and looked 10 years later, and none of the patients had any sort of progression. And so they realized that these are actually not an hemangioendothelioma. They're not intermediate malignant potential. They're truly benign, even though they can be multifocal. And because of their multifocality, they often arise inside like blood vessels, like, they can grow out of the middle of a vein. So they can be multifocal. They can recur. If I recall, this case had been seen quite some time, years previously. Another biopsy at the site had been done, or close to here had been done, and called, I think, cavernous hemangioma. And I think, reviewed that specimen. It had very minimal of this stuff. And it was only on when the lesion recurred, it had some multifocality, which looks concerning clinically. But when we looked at it, I said, oh, it's a spindle cell hemangioma. And these are totally benign, and it's normal for them to be multifocal. And that does look scary. If you do a scan and someone suddenly has, a couple different spots of a vascular lesion, that makes, the treating physicians worry that maybe it could be malignant, but it actually is a totally normal phenomenon. So I often add in my comment that these do tend to be multifocal, and they can recur, but they're not aggressive. So you don't need to do like a wide local excision. You just follow the patient, and if they recur and it's bothersome, then you can remove it again. And so the last thing, the kind of board spotter for this is, so spindle cell hemangioma is related to Maffucci syndrome, which is a germline mutation in IDH1 or IDH2 genes, the isocitrate dehydrogenase genes, which are Krebs cycle enzyme, if I recall correctly. And those patients develop multiple cartilage tumors in their bones, enchondromas that are benign, but they also have a higher risk of also developing chondrosarcoma, malignant cartilage tumor of bones. And they tend to get a lot of enchondromas in their hands, which can be quite deforming. And in addition, they will have a tendency for getting spindle cell hemangiomas. Now, the spindle cell hemangiomas I've seen in practice, except for I think one case, all of them have just been sporadic, not syndrome associated. And usually, if someone has Maffucci's, it's already known that they have Maffucci's. So because of the bone problems, finding a spindle cell hemangioma, I don't usually put in the report, oh, screen this patient for Maffucci's, because I think usually they will probably already know that the patient had Maffucci's well before they got their spindle cell hemangioma sample. At least that's kind of my current thinking. So these lesions, though, even when they're sporadic, they usually have mutations of IDH1 or IDH2. And I think this case, actually, because of the confusing clinical scenario and history, they wanted to have it tested, and I sent it off, and it was mutated for, I believe it was IDH1. So that was a nice confirmation. So kind of interesting and benign lesion, and that biphasic nature of the cavernous channels, and then the more cellular spindled zones with those little mini vacuoles that look like little mini fat cells, and the phleboliths, the calcs, if you find them, they don't have to be there. All those features together are good for spindle cell hemangioma. So they probably wanted skin tag, and this is just tangential sectioning. Quite pretty, right? But just an artifact of how we cut it in the lab, because it's cutting at an angle. So they wanted fleshy, skin-colored polyp. So skin tag versus nevus. But what we see instead is a spindle cell lesion with pink collagen in the background. some loose kind of edematous areas. Spindle cells are relatively haphazard, bland. Some of them are kind of pointed at one end and rounded at the other. Some are kind of like buckled or bent, like that. See how it's just kind of curved? Or like this, how they have like a little, where did it go? Like a little bend in the middle. Like I like to think like a Coke can, like if you pop the top of a Coke can and how the little tab like suddenly now has got like a little bend in the middle, that's what these cells look like. So that's a characteristic cytologic feature of Schwann cells. So these are Schwann cells, at least some of the cells here are Schwann cells. We also have a sprinkling of mast cells. The little fried egg right there. Oh, there's a better one up here. Right there. And they, depending on the, mast cells can vary from case to case, depending on how much of their granules they have left. When they have a lot of granules, they can look really kind of dark blue or purple. As they lose granule, they become kind of more of a fine light blue. And the granularity sometimes can be seen if you flip the condenser, probably not on here. But scattered mast cells, Schwann cells, look, little tiny, tiny baby nerve fibers, little nerve twigs almost. So I guess it's a little bigger than a twig, but it's a little nervelet, like a tiny, tiny little baby nerve, right? And so increased numbers of very small nerves mingled in here, and probably some fibroblasts and perineural cells. So all that put together, this is a neurofibroma, okay? So great, that's good. Neurofibroma. So why am I showing you? Well, neurofibroma with a bonus. There's kind of scattered cells that look pleomorphic, but actually closer up, they're actually some multinucleated cells. So they're kind of multinucleated cells scattered, these kind of almost floret cells. Some of them have like a ring or flower arrangement, like that one kind of does. So sometimes you can see multinucleated floret-like cells in neurofibromas. Sometimes you can see actual scattered big pleomorphic atypical cells in neurofibromas. And that can be seen in association particularly with neurofibromatosis type 1. I don't think of it as a definitive finding, but when I see pleomorphic cells, and I think the floret cells too have been suggested to be more common in NF1 patients. So I do think about NF1 in that setting. But even though these are weird looking, the neurofibroma is totally benign, even with scattered pleomorphism. And I have a much longer in-depth video about atypia and in neurofibromas in the setting of NF1 and how to think about malignant transformation, which almost never happens in the skin, even in NF1 patients. But I've got a whole long video about that, about NF1 and malignant peripheral nerve sheath tumor. So, ooh, and while we're here, a little bonus, look at that. That's a lymphatic channel with a valve. Sometimes you get the valve where you can actually see the opening, but here we're seeing that little thin leaflet, and here's another one there. Those are valves. Isn't that cool? It's real fun when you get the cut and you can see both leaves and the little opening in the center. But you know, when you see those, you go buy a lottery ticket that day because you're like extra lucky. So, all right. So anyway, floret-like cells in a neurofibroma, and I don't recall if this patient actually had NF1 or not. Any questions? I don't know if you guys are still there, but I assume that you are. If not, well, I'm making a video. Oh, look at that. If you don't like that, I absolutely cannot show you anything that will make you happy. That's like the best one I've seen in a long time. Wow, swoon. Any takers? Be bold.
Pinkus?
Pinkus, yes. Fibroepithelioma of Pinkus, which people have argued back and forth over, is it actually a basal cell carcinoma variant, or is it a variant of trichoblastoma, some sort of benign hair follicle tumor? I think there's decent evidence for it being a benign hair follicle tumor, even though I've always been trained to call it a basal cell carcinoma variant, and I believe that's what the current WHO says, because it does have kind of a stroma. It has some myxoid stroma like a basal would have, and sometimes has clefts, but also it can have areas that have the more kind of cellular stroma that hugs the basaloid nest like you'd expect in a trichoblastoma or benign hair follicle tumor. And additionally, some studies have found that you can have a scattered CK20 positive Merkel cell colonizing the lesion, which is a feature I usually think of for benign hair follicle tumors like trichoep or trichoblastoma, not basal cell carcinoma. But what I found more and more in practice is that the line sometimes between basal cell carcinoma and hair follicle tumors can be a bit blurry, and probably because basal cell carcinomas probably are hair follicle type tumors. Even though we think of them as epidermal tumors, they really have a lot of features that are akin to hair follicle tumors. And so I think, if I recall, I was on a panel a few years ago, and Phil LeBois was one of the people, and I think he believes, I'll have to double check this, make sure I'm not misquoting him, but I believe that he was one who either published on this or believes that these are probably a variant of a benign hair follicle tumor, of a trichoblastoma. And what he said is that in any case, of the cases he's seen, he's not seen one have aggressive behavior or be associated with like an aggressive, aggressive type basal cell carcinoma. So even if it is a basal cell carcinoma, it seems to be an indolent, non-aggressive form. So I thought that was interesting input from someone who's seen an enormous amount of Dermpath, way more than I have. So I did skip right past how do we recognize Pinkus for anyone online watching this and wondering. So Dr. Pinkus was one of the founding fathers of dermatopathology, and so this tumor bears his name. And Fibroepithelioma of Pinkus, or I usually will put them as basal cell carcinoma, Fibroepithelioma of Pinkus type, and then I add a comment that some people think they're a benign hair follicle tumor, and some people think they're basal. Sometimes I'll add that comment. My views have kind of changed over the years, but what we see is this kind of net-like or fenestrated pattern, and fenestrae means windows, right? So what we have are these elongated, thin branches stretching down from the epidermis in multiple places and interconnecting together, and then you're getting islands of dermis in between, and these islands are kind of like windows, right? This is a lattice work of interconnected strands of epithelial cells with windows kind of in the middle of it, right? And so let's talk about the epithelium. All right, I feel like one thing that helps me with Pinkus, because there are sometimes some other things that can look a little similar, particularly syringofibroadenoma. Or syringofibroadenomatous epidermal changes can have some of this downward net-like growth, but they're a little different. The texture of the epithelium or the quality of the epithelial cells is different. So what I think of when I think of Pinkus, and this is maybe the color of this is not the best example to show it, but the pattern is so beautiful, is I feel like you get two different looks. You get these strands here, which oftentimes the strands tend to be a little bit more pink. In this case, they're a little bit more blue, but they are kind of like I think this slide was just a little darkly stained, but they look more like keratinocytes, like the epidermis. So you get strands of stuff that looks similar to epidermal keratinocytes, and then coming off of that, you begin to have little buds that look more basaloid and have the really nice, like palisading kind of basal cell carcinoma or trichoblastoma type of look. So I feel like that's the thing that helps me, is that you're getting two things. You're getting the strands of keratinocytes, and then you're getting little buds that look like basal cell carcinoma. And again, this may be the best example I've seen of the stroma really, really, strikingly resembling the stroma of a benign hair follicle tumor. It's when you see the cells that are the stromal cells that are getting oval or round and then hugging and clumping up right against the basaloid palisading without any cleft in between, that's exactly the stroma I want to see in a trichoep or a trichoblastoma. And what's happening is that this is basically akin to what you see in papillary-mesenchymal bodies, right, which are the kind of classic finding in trichoepithelioma. And look, those look perfect for papillary-mesenchymal bodies, these little round cell areas. If you stained that are kind of trapped in the middle here, if you stain those with keratin, they'll be negative because they're actually stromal cells. I think they'll stain with CD10, actually. The stroma around hair follicles is kind of special and is usually pretty strongly positive for CD10. So, pink strands with blue basaloid islands. And then here's an area that I think probably just represented a little rupture and inflammation, and you're getting kind of a busy desmoplastic kind of area like you would see like in an infiltrative basal. But when you look at the whole tumor, clearly it's not infiltrative, right? So I think this is kind of what's happening right here. You can see in a variety of adnexal tumors and also in basal cells, of course, but you can see this pattern of more pink kind of strands with a background of stroma that's very busy and kind of myxoid and spindly. You can see that in the setting of kind of a inflamed or irritated area in the middle of tricholemomas, what we call desmoplastic tricholemoma. That kind of pattern of basically a reactive change that's mimicking infiltrative basal, you can see that not only in desmoplastic tricholemoma, but you can see it also in a variety of other adnexal things. And sometimes if you don't have the whole lesion, it can really cause a concern for an aggressive malignancy. But that's more of that stranding. And then basaloid islands right there. So, Fibroepithelioma of Pinkus. And then look, let's see that we do have a little bit of clefting over here. So it's a bit of an enigma, right? It has that stuff right there. You'd think the cleft would support basal cell. So I don't know what the real answer is. And smarter people with me have argued over it and not totally resolved it. So I'll just tell you that there are different views on it, but whatever name we call it, it's quite pretty and it does not seem to cause serious problems for people. So I think it'd be reasonable to either do a conservative management of it or at least watch it, afterwards to make sure it doesn't recur. But I don't think probably aggressive treatment is needed. But that's just my thoughts as of January 2022. Oh, look, wait, one last thing. I'm sorry, I can't help myself. Look at that. What's that pink stuff?
Amyloid.
It's amyloid, and it's keratin amyloid. Anytime the amyloid's like right around an epithelial tumor, be it a basal, be it a seb, be it a Pinkus or trichoblastoma, anything, that is keratin derived from epithelial cells that have dropped out keratin. And one of the clues, it's pink and it's smudgy like amyloid, just like light chain amyloid would be. It will stain with I don't know, Congo is iffy to me. The books I think say it's positive, but I find Congo hard to interpret sometimes. But thioflavin T beautifully lights this stuff up. You have to have direct immunofluorescence, an immunofluorescence microscope to be able to read it, but it's quite beautiful, turns bright green. So the thing to me is that it looks like amyloid, but it's right next to the epithelial stuff trapped around the tumor, or in the case of macular amyloid or lichen amyloid, it's in the papillary dermis. And then also in the cracks, it often has pigment. And that's because as the epithelial cells break down and smash together, it's kind of almost like cytoid bodies that are getting all packed together. That's the way I kind of think of it. And as that process happens, the melanin pigment that was contained in those cells, because look, basal cells and sebs and sometimes trichoblastomas and trichoeps, they often have pigment in them, melanin pigment from kind of passenger melanocytes that are colonizing them. So that pigment drops out too, and the pigment gets trapped up in between the pink. So pink amyloid that has melanin, brown melanin pigment in the crack spaces, and that the amyloid is right next to epithelium. Usually that's going to be keratin-derived amyloid, which is totally unrelated to light chains or myeloma or systemic, amyloidosis or any of that. So that's important. So when I see that, I actually just point it out to the residents, and then I don't even mention it in my report, because otherwise it's going to cause angst to someone who may not know and sees the word amyloid. And amyloidosis, systemic amyloidosis, is a very serious, condition. So that's important to know that keratin amyloids are unrelated to those. Beautiful example. Wow. I can't do any more work today. I need to go home now. It's just too awesome. Okay, maybe I can work a little bit more, because this is pretty good too. Ooh, the slide's pretty dirty. Let me see if I can clean that up. Maybe it's under the cover slip. I don't know. Oh, yeah, it must be in the mounting media somehow. All right, so we've got something in the dermis here, multiple islands and nests with some cystic spaces in them. Very focal connection to the epidermis. Look at those cells. They're so pretty, right? Because they're just so perfectly round and monotonous. And as you guys probably know well by now, I love like perfectly round monotonous things like glomus tumors and stuff like that. I don't know why, it's just so visually appealing. And look, you know what's interesting where it connects to the epidermis? The sharp cutoff, like that's the edge of the tumor right there. And then that's the epidermis. I'll go closer to show you. I find that sharp cutoff really helpful for this group of tumors. And then we have cystic spaces, and they have some secretion in them, some dried up secretion. And over here, what you can see is that this cystic space is actually a dilated sweat duct. And here's the secretion is one evidence of that. And number two, look, right next to it, we've got little tiny ducts. And sometimes it's hard to tell a true duct from just an artifactual hole in the tissue. So one thing when I'm looking for ducts in an epithelial tumor to look for a nexal differentiation, which is what's going on here. I like if I see a hole that's lined by this really dense, sharp line of pink, we call that the cuticle, okay? And so that little pink cuticle lining the inner surface of a sweat duct in a tumor, that's really helpful evidence that you are dealing with a true sweat duct. Sometimes the duct space will actually be lined by their own little cuboidal or columnar cell layer that looks different from the cells of the rest of the lesion, and that's really helpful too. I thought I saw that over here somewhere. Yeah, you can kind of appreciate it here, right? Like a little bit. Like see this one right here? See how the cells are like lined up right around the edge of the channel and they look kind of different, like different in their arrangement at least than the rest? These are all sweat ducts too. Here, 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 there. Here's a dilated one. Here's more. So it's nice. Sometimes you really have to hunt around to find sweat ducts in this type of tumor, but in this one it's abundant. There's also, these are not ducts here. These are actually glycogenated cells, actually epithelial cells, so that's actually clear cell change. And then the stroma, this is also not a duct. This is actually dermis, because how do we know it's dermis? It's got blood vessels in it, right? Blood vessels don't run in the middle of epithelium, and they certainly don't run in the middle of a cystic space. They're in the dermis. So if you can see a blood vessel lined by endothelial cells and you've got some blood in it, doesn't matter how pale the stuff around it is, you're actually in the dermis. It's just the dermis has a bunch of edema, which is pretty common in sweat gland tumors, particularly this one. So this is an example of something in the Acrospiroma family of tumors. I think of them as a family that have a few different lesions in it that all are closely related. So hydradenoma, clear cell hydradenoma, nodular and cystic hydradenoma, eccrine, apicrine, whatever name you want to apply to it, hydradenoma. And then poroma, which poroma and hydradenoma have very similar features. The difference is that hydradenoma usually grows as a nodule or multiple nodules down in the deep dermis or sometimes even the subcutis. Poroma usually grows in the epidermis and sends elongated finger-like, elongated, expanded reedy down. And then you have something like this, which looks kind of like an overlap between those two, but is sitting here in the superficial dermis, but in this section, not connecting to the epidermis. So if you wanted, you could call, on this section here, you could say this is a dermal duct tumor. So dermal duct tumor kind of is basically, it looks like a hydradenoma, but it's very superficial in the dermis, or like a poroma, but doesn't have a connection to the epidermis. And the point that some people have made is that there's maybe no such thing as a true dermal duct tumor, that if you just cut deep enough, you'll eventually find a connection to the epidermis. And I'll tell you what, even though we often teach hydradenoma as being a deep nodule not connected to the epidermis, I would say about 10 or 10%, 15% of hydradenomas I've seen have areas of connection to the epidermis. And the reason I learned this is because sometimes I've seen lesions that on a shave biopsy were called poroma, and then a surgeon went and excised it, and on the excision it was clearly hydradenoma. So I've seen basically what look like poroma, hydradenoma, hybrid tumors, and that makes perfect sense because they are part of that same Acrospiroma family. And all of them are defined by basically one cell type, as opposed to like, Spiradenoma and Cylindroma, which are a separate family. Those are more blue, and the Acrospiroma family is more pink because they have more abundant cytoplasm. They look kind of like keratinocytes, right? And in the deeper hydradenomas particularly, you tend to have a lot more kind of squamoid, keratinized looking cells. In the poroma end of the spectrum, you tend to have much smaller, rounder cells with less cytoplasm. So sometimes we say that these are poroid cells, if they're very small and round and like very perfectly uniform and monotonous like this. And particularly in poroma, when you have this epidermal connection, poromas or hydradenomas that connect to the surface, either way, they tend to have a very discrete, sharp cutoff. They're one of the epidermal tumors that have a sharp cutoff between the tumor and adjacent normal. Another tumor that does that doesn't really look like this, but would be clear cell acanthoma. Also has a very sharp, discrete demarcation between tumor and normal epidermis. So here, it'd be easily to just call this benign acrospiroma, or you could say dermal duct tumor if you want. It doesn't really matter. They're all benign. They're all the same spectrum. And we wrote a paper a few years ago about adnexal tumors for surgical pathologists in plain language to try to be morphologic and practical rather than focusing on the esoterica. And my former fellow Ed Fulton did a really great job first authoring and putting that paper together. And I liked one concept that he basically came up with and said that he liked this idea of this is kind of like pink modeling clay. And it's the same stuff. It's just if you make it deeper nodules, hydradnoma. You make it some nodules in superficial dermis, dermal duct tumor. You make it some finger-like projecting reedy that are expanded and sticking down from the epidermis, poroma. If you put it just in the epidermis without the expanded reedy, you can call it another thing, hydroacanthoma simplex. So we've got like all these different names for basically the same tumor that just has a morphologic range. And I thought that was a really nice way to explain that. If you're watching online, I'll put a link to that paper down below. It's free on Archives of Pathology. But I thought Ed came up with a really, really nice practical concept there, and I like that a lot. But these are pink tumors, and they do tend to have a lot of clear cell change in some cases. In this case, it's only focal, but hydradnoma or dermal duct tumor or acrospiroma, whatever you like, same basic concept, and it's benign in this case. There are malignant forms, or they're much more uncommon, of course, but there are some malignant forms, but they're going to have a lot of atypia and infiltrative growth. Oh, and you can have calcifications in many different tumors. You can have calcifications. All right, we'll do one last one, and we'll call it a day. 2, 4, 6, 8. We've done 8 cases. I'm like leisurely taking my time as opposed to the 30 cases I try to normally get through and never can do it. So let's see if this one looks good. So we got a little bit of spongiosis right here. So spongiotic dermatitis. Looks like it's been going on a little while because we got some hypergranulosis. So it's starting to kind of lichenify. The epidermis is getting thickened and acanthotic. That acanthotic epidermis and hypergranulosis are both signs of kind of chronicity. Look, we also got a folliculitis. We got a pustule down in the follicle. You can still see the hair shaft right there, a little tiny hair shaft. And the one thing I notice here is look at how dense pink the stratum corneum is. So maybe that's just due to like kind of scratching or lichenification, but one thing you want to think of when you see a real dense, compact orthokeratin is I think of fungal organisms like dermatophytosis. And also if you're like in the axilla or the anogenital region, you can also think of erythrasma, which is caused by Corynebacterium minutissimum. And both of those tend to produce a really dense corneal layer. And in this case, it's fungus. And oftentimes on dermatophyte fungus, tinea, I often struggle to see the fungus even when they're abundant. They're usually clear. But in this case, they do have a little bit of a kind of purplish color to them, and you can see the little holes they leave in the tissue. But I got to look around for a while. So notice that's another thing about fungus. When you're looking for fungus, whether it's on H&E or on PAS or GMS stain, look carefully because I've almost overlooked it before. It's not always florid. It's sometimes very focal, even in a patient that has a pretty extensive, overgrowth of fungus clinically. It can sometimes be pretty focal on the slide. That's also a reason too that just because a biopsy was done and was negative for fungus or a KOH was negative for fungus, don't totally exclude the possibility of tinea or other fungal infection from your differential clinically. If the process still persists after steroid treatment or whatever treatment you're using, keep in mind if you think it could look like fungus, then maybe try a trial of antifungals or consider doing a repeat biopsy or repeat scrape because I've seen times where it was very focal. Same goes for nail clippings. I've seen times where you have this big, thick, abnormal nail that looks like onychomycosis clinically and a large sample comes out and the fungus is only focally on the clipping. And I thought, man, if I had a smaller clipping, I would have called it negative. It's only because I got a big enough clip that I happened to get the area that had fungus. Now, plenty of nails are loaded with fungus, just like plenty of cases of tinea have lots of fungus, but there are times where it's focal. So just keep that in mind that it's not perfect, KOH or a skin biopsy can sometimes miss those things. Even if the pathologist is not missing it, I mean, they just may not be showing up on the sections. And look here, this is another feature to remember too, that when you're thinking about dermatophytes, check in the hair follicles, because sometimes you have dermatophyte extending down the hair follicles. You can see it right here, and it's kind of got a purplish stain. Normally, again, dermatophytes are clear on H&E, and like Malassezia or Pityrosporum, and also Candida are almost always bluish purple like this. But every once in a while, and I don't know why it is, every once in a while I'll see dermatophytes actually show up and be visible as a purplish blue on H&E. But most of the time in my lab, at least in my experience, they usually are clear. But you can see them here. Look, there's one, here's one, there's one. It's a little bit up here. So, and when in some cases they can go down and just involve the hair shaft, in which we call, particularly like in tinea capitis on the scalp, and we call that either endothrix or ectothrix pattern of infection. And in those cases, you may not have any on the surface, so don't forget to check the hair follicles. And sometimes, there's like no inflammation. This follicle has spongiosis, but no inflammation. All right, so there's the fungus in the follicle. Now look over here. We see another follicle, but this one is filled and distended with neutrophils, and it's got some inflammation in the dermis around it. All right, so this is a pustular folliculitis or suppurative folliculitis. Now, normally when we see this, it's often associated with cocci bacteria, but in this case, where there's dermatophyte fungus present, probably this indicates that there's more of that fungus growing down into the hair follicle with associated folliculitis, so kind of a fungal folliculitis associated with dermatophyte. And I don't see any of the hyphae in here, but that's probably what's going on. And so I actually pulled a couple extra slides from this case, other sections, to see if we could see it more clearly. Here's another view of that same follicle. And look at the difference, just a slightly different section, just a little bit deeper into the block, and you've got the pustule again in the follicle, and jackpot. We can actually see the fungus right there. So again, the sampling and the sectioning can really make a difference, and especially this is a case that's really pretty loaded with fungus. Sometimes the fungal organisms are much more sparse than this. So there's a dermatophyte fungus extending down a hair follicle. And so when we see this kind of finding often goes hand in hand with what is called Mayaki's granuloma, M-A-J-O-C-C-H-I, Miyake granuloma. So these, lesions look more kind of indurated and firm plaques clinically and have a granulomatous appearance. And what I was always taught and what the books say is that Mayake's granuloma is supposed to be dermatophyte fungus causing a folliculitis, and then the folliculitis ruptures and the fungus and the inflammation spills out into the dermis. But I'll tell you that in practice, I have almost never actually seen the fungus out in the dermis around the follicle. Almost always when I see lesions that clinically fit for Mayake's granuloma, microscopically what I see is just dermatophyte with folliculitis, and then there's perifollicular inflammation of varying amounts, but I don't actually identify the fungus in the dermis. So even though the books say, at least what I've read, say that the fungus should be spilled out of the follicle into the dermis, I feel like in practice I almost never encounter that, and instead, if I just see fungal folliculitis like this with dermatophyte hyphae down in the follicle, to me that's enough to fit with what clinically is called Mayake's granuloma. So anyway, you can do some more reading about that if you like, but that's been my experience at least. Let's look at another section on here, because this is a pretty nice example. And here's a different follicle out towards the edge of the shave biopsy. And what do we see? The same thing going on. We see the fungal hyphae up here in the stratum corneum. Look at again how compact that orthokeratin is. I find that real dense pink orthokeratin right away. I think of dermatophyte. And then we see these fungi going down this opening, this infundibulum of a hair follicle with associated neutrophils. And again, the neutrophils kind of spill through the follicle and outside, but the fungus in this case, again, is confined to the follicle, at least in the sections that I've looked at. And here's another follicle with a little bit more of the same, some fungi here. And so, if I recall correctly, Mayake's granuloma is often on like the anterior legs is where you tend to see this for some reason. The other place where you can see dermatophyte causing a folliculitis involving the hair follicle is in the scalp in the setting of tinea capitis. And we don't often see that biopsied, but when you do, you'll see, numerous follicles just completely loaded with fungus, either in the hair shaft or surrounding the hair shaft, or a combination of those, and then a brisk inflammatory response with it. And so you can see this same kind of pattern in tinea capitis, tinea of the scalp. And I think there was another section over here, where you can see the same thing again. That follicle we just looked at, and look now as we cut deeper, it kind of opens up more. We see more of the inflammation in there and more of the dermatophyte fungal hyphae. So this is a nice case to demonstrate this concept, and also it's a good reminder of just how much things can change from section to section and why we order deeper levels so often in dermatopathology, because oftentimes the deeper level really saves the day and shows us the finding of interest. So tinea or dermatophytosis, and there, look, here's some more right in this piece. And it's just a simple fungal infection, ringworm, not going to be fatal to the patient. But I've seen cases where dermatophyte wasn't thought of and wasn't biopsied or scraped and was treated with steroid for a long time, sometimes years, and I'm sure you've all seen this too, and then it leads to tinea incognita, which is basically very extensive and sometimes severe looking, rash clinically that keeps getting worse no matter what steroids you put on it, because you're basically knocking out the immune system and letting the fungus overgrow. And then those patients can, it can be very disfiguring and also uncomfortable. And I've seen patients that unfortunately have had years of untreated dermatophyte or improperly treated because they were treated with steroids and never sampled. So if you're watching this and you happen to be a non-dermatologist or a new dermatologist in training, remember that if you get a rash that continues to get worse with steroids, check for fungus, please, or at least try an antifungal therapy, because that's a significant problem. And I've seen some pretty bad cases of tinea that have really caused a lot of morbidity to the patient for a long time. So the simple fungus, even though it's common and simple, still can be a real problem for people. Not everything that's bad is cancer. There are plenty of non-cancerous rashes or infections that can actually really dramatically cause quality of life and morbidity for patients, even if they're not deadly. All right, guys, I think that's enough for one day. Thanks for tuning in if you're online and watching, and everyone have a great day.
Thank you.
Thank you.